Thank you so much for having me this afternoon. I'm sorry that I couldn't be there in person. I'm excited to talk with you about long COVID among individuals who are pregnant at the time of infection. I do have some disclosures. I have worked as a site PI for a number of Pfizer studies including one of COVID-19 vaccination in pregnancy, one of the RSV vaccine in pregnancy, and then a pharmacokinetics trial of Paxlovid in pregnancy. I also participated in the medical advisory board for the Pfizer COVID-19 vaccine trial. Today, we're going to describe the effect of COVID-19 pandemic on the outcomes for pregnant people and their offspring, and describe the current evidence surrounding long COVID in individuals who acquired SARS-CoV-2 during pregnancy and potential for therapies in the future. First, I just want to lay the groundwork a little bit in terms of how pregnant people were affected early in the pandemic. These data are really old. They're from November of 2020. So the first sort of fall moving into the winter of this pandemic, when the CDC put out some data through the maternal morbidity and mortality, the MMWR, morbidity and mortality report of cases submitted to the CDC from January 22nd to October 3rd of 2020. In the cohort, there are 1.3 million females of reproductive age who tested positive for SARS-CoV-2. And data on pregnancy status was available for 35.5 of these individuals. 88.7% were symptomatic, and among those symptomatic people, 5.7% were pregnant. And what they found in this work is that after adjustment for important covariates, including age, comorbidities, race, and ethnicity, pregnant individuals were at increased risk of ICU admission, need for mechanical ventilation, and risk of death. They also found that disparities were very prevalent. Individuals who identified as Black represented 14% of the cohort overall, but 37% of the deaths overall and 27% of the deaths among pregnant people. And so these data really sounded the alarm very early on that SARS-CoV-2 could really affect pregnant people differentially when compared to those who were not pregnant. This led some work that we did initially to form a cohort that has then subsequently been followed in the RECOVER study, the NIH RECOVER study, which I'm going to talk about. But initially, we did actually an observational study just looking at the effects of SARS-CoV-2 itself in pregnancy. And this was called the National Institute of Child Health and Human Development Maternal Fetal Medicine Units Network GRAVID study. GRAVID stood for Gestational Research Assessments of COVID-19 in Pregnancy. And these are all the sites that participate in the Maternal Fetal Medicine Units Network. So you can see that they really are across the United States. So when we did this study, it was a large retrospective cohort study of 17 US hospitals participating in the MFMU. And we did detailed medical record abstraction on 14,104 pregnant and postpartum patients who delivered in the first year of the pandemic from March to December of 2020. Overall, 2,352 of the patients had SARS-CoV-2 infection during the pregnancy, and we compared those without SARS-CoV-2 who delivered on randomly selected dates over the same time period, so 11,752 controls. And what we wanted to look at with this study as a primary outcome is maternal death or serious morbidity from common pregnancy complications, including hypertensive disorders of pregnancy, postpartum hemorrhage, and infections and other than SARS-CoV-2. And the reason we want to look at this is because we knew already that SARS-CoV-2 had differential effects on pregnant people and that they had a higher risk of death. But what we wanted to also know is when we compared them to other pregnant people, were they at higher risk for other morbidities during that acute infection time period? And specifically, were they at risk for some more serious complications of things that we see pretty frequently in pregnancy? And so we weren't just looking at somebody having, a postpartum hemorrhage. We were looking at somebody needing to have significant interventions for that hemorrhage, things that may have resulted from delayed presentation to care, delays in care. And what we found in this initial study that was published in JAMA was that people who did have SARS-CoV-2 during pregnancy during that early pandemic were at higher risk for composite death or serious morbidity than those who didn't have SARS-CoV-2. And the top line there with adjusted relative risk of 1.41. And that was largely driven by hypertensive disorders of pregnancy, so high blood pressure in pregnancy that then led to complications like having seizures, having strokes, and infections other than SARS-CoV-2. But interestingly, we found that those adverse outcomes were really among those who had moderate or higher disease severity. So people that were needing to be admitted to the hospital, people that were requiring oxygen. And so what we were able to identify with the study was that we needed to prevent progression to higher disease severity, and that we could do that with vaccines and treatments for COVID-19. And I think, this was important finding, and potentially also now contributes to differential effects that we can see in the development of long COVID, because we know that many of these things are also associated with development of long COVID. Early in the pandemic, there was a lot of vaccine hesitancy broadly, but especially among people who were pregnant. And I think that that was really a result of not having any data on pregnant people, not being able to reassure them that we knew that the vaccine was safe and effective in pregnancy. And so understandably, people were uncertain about taking it. They were in a hard spot where they knew that it was an effective vaccine. They knew that it had been tested in other people, but that just hadn't been tested in pregnancy. Since then, there's been a ton of work on this, fortunately, and this is a systematic review and meta-analysis that came out of 23 studies, including a large proportion of vaccinated pregnant people. Effectiveness was very high at 89.5% against SARS-CoV-2 infection 7 days after that second dose. These are all mRNA vaccines. The risk of stillbirth was lower in the vaccinated population. And we definitely saw this with especially certain variants like the Delta variant in pregnancy was very bad for placentas, and we saw a lot of stillbirth at that time. And we found the vaccine was protective against it. There's also no evidence of higher risk of miscarriage, earlier gestational age at delivery, abruption, pulmonary embolism, which is a blood clot in the lungs, postpartum hemorrhage, maternal death, ICU admission, lower birth weight, or NICU. And so really trying to provide reassurance to pregnant people and their physicians that it's okay to give this vaccine in pregnancy. We also know now that the vaccine is effective against neonatal disease. This is a case control study that was published in the New England Journal of Medicine. They followed 537 case infants who were hospitalized for COVID under 6 months of age. 16% of the cases and 29% of the control infants had been born to unvaccinated mothers. And overall, that they found that the effectiveness of maternal vaccination against neonatal hospitalization for COVID was 52% overall, and 69% efficacy administered after 20 weeks gestation. And this is not, surprising. We give a number of vaccines in pregnancy specifically to have a maternal antibody response that can then be protective to the neonate, things like pertussis vaccine, and then most recently the RSV vaccine. So I just wanted to lay that background about what we learned during the initial pandemic first. And, there really was a lack of information about SARS-CoV-2 in pregnancy, and that led to a lot of fear. There were a lack of clinical trials for vaccines and treatments that included pregnant individuals, which really led to a lack of knowledge. And pregnant people experienced adverse outcomes due to being excluded from clinical trials, because we now know that these therapies are safe and effective. And unfortunately, we weren't able to distribute them as widely as we could have. So now getting into more long COVID and what's next, now that we've sort of laid the groundwork for, what happened to pregnant people during the pandemic and what some of the issues were, the question is, where do we go from here? This is how the NIH Recover Pregnancy cohort came to be. And so we took that initial cohort of gravid patients where we saw this differential effect among pregnant people with SARS-CoV-2 acquired during pregnancy. And we wanted to say, then look further and say, how does pregnancy then affect post-acute sequelae of COVID or long COVID? And as a network, we applied to be part of the Recover initiative. And I would say at this point, it still remains unclear how pregnancy affects the development of post-acute sequelae of COVID. And I'm going to show you some initial data that I think are really interesting. The NIH Recover cohort is designed to understand the prevalence and pathophysiology of PASC. And we established a Recover pregnancy cohort to follow people with SARS-CoV-2 during pregnancy, because we may observe differential prevalence or risk factors, which may help with our understanding of pathophysiology of long COVID, and then hopefully that would in turn lead to effective therapies. So the first work that we did as part of the NIH Recover Pregnancy cohort initiative was to estimate the prevalence of post-acute sequelae of SARS-CoV-2 infection, PASC or long COVID, and I'm using those interchangeably, after infection with SARS-CoV-2 during pregnancy in the Recover Pregnancy cohort, and to characterize the associated risk factors. And these data were previously presented at a scientific meeting, and so they are out in the public domain. I'm able to share them here, hopefully published soon. So what we found is that 9.3% of our pregnancy cohort met criteria for long COVID. And for this particular study, we defined long COVID or PASC based on the PASC score that was established by the Recover cohort in a JAMA publication in 2023. We recognize that this is really a research score and doesn't really identify all the patients who have PASC. But I think it was a useful benchmark specifically for this study because we're able to think about it in the context of other publications that have similarly used this score. And it was still a large proportion, 9.3% of people who acquired SARS-CoV-2 during pregnancy met criteria for PASC. And in this study, the median time that we were examining them from the index date to the PASC defining study visit when we were examining their symptoms, signs, severity of the symptoms was 10.3 months from that initial infection. So I think that's important just for context because we know that over time, the symptoms of long COVID wax and wane. We also know that over time, some symptoms improve. And so it's important to know that we were examining these patients at a median of 10 months, but ranging an interquartile range of 6 to 21 months. And what you can see on the right there is the frequency of various PASC scores. Patients had to have at least a PASC score of 12 in order to be classified as having PASC, and everybody else was classified as PASC indeterminate. And what you can see is that a lot of them did have a PASC score of exactly 12, but one participant had a score as high as 31. The PASC symptoms in this pregnancy recover cohort were predominantly post-exertional malaise, fatigue, gastrointestinal illness, dizziness, and brain fog. And these are very similar to what we've seen in the broader recover adult cohort that includes non-pregnant adults as well. We also wanted to look at risk factors for PASC or long COVID. And so we looked at a large variety of factors that could potentially be involved or associated with the development of long COVID. And at the bottom there, you can see that we did look at age. We looked at era of infection, meaning, variant of SARS-CoV-2. We looked at the patient's insurance status, their score on a discrimination index, whether they've been vaccinated, whether they use tobacco, other medical comorbidities, the number of prior pregnancies, and we also looked at trimester of infection. But the ones that we found to be significantly associated with the development of long COVID are shown in the table here. They included that covering expenses was difficult in the month prior to infection, obesity in the year prior to infection, depression or anxiety, pre-existing infection, and a higher disease severity, meaning that they needed oxygen at the time of their acute infection. So certainly higher disease severity has been associated with long COVID in other studies. So has vaccination, which I'm aware of, and I think that has come up as to why that didn't remain significant in our models. It was in the direction of protection, but when we put all of these other covariates into the model, it was no longer statistically significant. But it'd be interesting to look at this in a larger cohort. So what did we find? That 1 in 10 individuals with SARS-CoV-2 during pregnancy will develop PASC or long COVID. Symptoms include predominantly post-exertional malaise, fatigue, and GI symptoms. Socioeconomic and clinical characteristics were associated with the development of PASC, and the rates of PASC among pregnant populations may be lower than non-pregnant adults, with estimates ranging from 10 to 25% in the adult recover cohort, depending on how you break it down, and 9% in our cohort. So we want to look more at this and to try to determine if people who have SARS-CoV-2 during pregnancy actually do have a lower rate of subsequent development of long COVID, because that could really help us think about the pathophysiology of long COVID and maybe give us some clues into ways that we could develop some treatments. So we did start to look at this in collaboration with the Recover EHR cohort, or the electronic health record cohort. This is a group of investigators who have access to some very large databases of patient medical records that are de-identified, so that they can really look at the population level at how various risk factors or exposures play into the development of long COVID. And so for this particular study, we looked at EHR data from 19 US health systems of females aged 18 to 49 years with lab confirmed SARS-CoV-2 infection from March of 2020 to February of 22. Our primary outcome for this was PASC 30 to 180 days post SARS-CoV-2 infection. And this, we just use a definition that's consistent with the definition that's been used for other adult EHR cohort studies. And our exposure that we wanted to look at was acquisition of SARS-CoV-2 during pregnancy compared with people who acquired it outside of pregnancy. So female sex at birth who acquired SARS-CoV-2 outside of pregnancy versus those who actually had it during pregnancy, to see if we saw a difference in then development of long COVID. So overall, in this initial study that's now published in eClinical Medicine very recently online, there were 83,915 non-pregnant females and 5,397 pregnant females, and they differed by baseline characteristics, not surprisingly. In general, the people who had SARS-CoV-2 during pregnancy were overall younger, healthier, which we would expect to see, but we did go ahead and match them using propensity score methodology, and were able to achieve matching. And what we found out, even after matching them for those differences in baseline characteristics, was that SARS-CoV-2 infection during pregnancy compared with outside of pregnancy was associated with lower incidence of PASC. So pregnant people, 25%, non-pregnant, 34%, with an adjusted hazard ratio of 0.85. And so this is consistent with the data that we got from the prospective observational cohort, where we're sampling people and looking at their symptoms over time. This is using more of a digital definition of PASC that's been used in other studies. And you can see those rates overall are pretty high, but using the same definition across the board, we did find that having SARS-CoV-2 during pregnancy did seem to be somewhat protective against development of PASC. And we have some different hypotheses for why that could be. We know that in pregnancy, pregnant people have very different immune responses, which could certainly make a difference. Overall, they're much more immune tolerant, so they wouldn't have quite the same inflammatory response as people who are non-pregnant. There's also still a potential for some residual confounding, where these are potentially just a healthier baseline population with less comorbidities and less predisposition to PASC. And so this is something that we do want to investigate further. So the remaining questions are just, are offspring affected? And when we initially submitted to do this work, we were really interested in, we have this maternal hypoxia and inflammatory response, we have placental damage. Does that then translate into differences in perinatal outcomes, which we have seen, and we know it does, that we do see an increased risk of adverse pregnancy outcomes, but also long-term outcomes for the offspring in terms of their social, emotional, neurobehavioral development, and any adverse cardiometabolic outcomes. There are a couple of studies out there on this. One was published in JAMA Pediatrics, where they had a prospective cohort of 255 children. 114 had been exposed to SARS-CoV-2 and 141 unexposed, and they had 62 historical cohort pre-pandemic children to compare them to. They performed something called the Ages and Stages Questionnaire, which is a neurodevelopmental test at 6 months of age. And they found that birth during the pandemic, but not in utero exposure to SARS-CoV-2, was associated in a difference in neurodevelopment at 6 months. There's also a large EHR study on this, where they had a retrospective cohort of 7,772 live births and 222 births to SARS-CoV-2 positive mothers. And what they did for this study is query diagnostic codes and labs for 8 hospitals in the Northeast from March to December of 2020. And what they found is that a COVID positive mother was associated with an increased odds of adverse neurodevelopmental diagnosis, with an adjusted odds ratio of 1.86. So this study did find that there was more commonly neurodevelopmental diagnoses in babies who had been exposed to SARS-CoV-2 in utero. Now the question is there bias there? Were these babies being tested more frequently? Are there other reasons for this? But I think, this does, raise the flag of, are there differences? And certainly we need to continue to explore them. I think there's a lot of remaining offspring questions that we're hoping to answer with some work we're doing now. The question is it exposure to the pandemic and societal changes of the pandemic, or the exposure to SARS-CoV-2 itself that is potentially causing differences in neurodevelopmental outcomes? Do the findings persist when compared with controls who are unexposed, who are evaluated in the same way? So really using rigorous methodology, where we're having controls and cases that are evaluated in the same way, using the same testing. And does initial COVID-19 severity matter? Or like we see for the adverse pregnancy outcomes, is it really those patients who had moderate or higher disease severity that really have effects on their offspring? I think there's a lot of remaining pregnancy questions as well. And this is something that we've been working on and something that has come up a lot with the patient representatives who are involved in the recovery initiative. The thing that they're interested in now is not just what are these initial effects from SARS-CoV-2, what's the risk of then developing PASC after having SARS-CoV-2 in pregnancy, but really extending this and trying to think about pregnancy outcomes among those who have a pre-existing long COVID diagnosis. So now patients who had SARS-CoV-2 now develop long COVID want to get pregnant, and they want to know what their pregnancy outcomes will look like and if there are any increased risks of having a pregnancy with a diagnosis of long COVID. I think this is a really important question, and we're going to need population-based data to answer this. We also really need to be able to try to ascertain early pregnancy loss data, and that can be challenging with electronic health record data, just because sometimes patients have early pregnancy losses at home and don't necessarily seek care for those losses. And so this is something that I think is a really important issue, something that has really come up fairly frequently with our patient representatives and patients in clinics, and something that we really do want to answer in the future. And then also, what are the offspring outcomes among people who have pregnancies when they already have long COVID? So in summary, COVID-19 had a huge ongoing societal impact, as we're all clearly aware. We continue to observe excess deaths from COVID-19. And long COVID is a public health crisis that warrants ongoing attention. The incidence of post-acute sequelae of COVID or long COVID may be different when SARS-CoV-2 is acquired during pregnancy. It seems like it may be lower, and this is something that we need to continue to evaluate. It may help us to then understand when we're considering the pathophysiology of long COVID and the potential therapies. If this does seem like it is lower in pregnancy, why? We can start looking at the immune response, what we're seeing in the patient's blood at the time of initial infection, so which we have that stored for some patients. And maybe that's the differential effect. If there's other things, hormone levels that are very different during pregnancy than outside of pregnancy, could that be contributing to the difference? All these are things that might help us then develop therapeutic options. And the effects on the offspring remain largely unknown. I shared with you a little bit of data. There was also another recent study that just got published out of the UK, but we really just don't know a lot about that. And so we're hoping to really answer those questions as well. I'd like to thank the Eunice Kennedy Shriver National Institute of Child Health and Human Development for funding the MFMU GRAVID study, the National Heart, Lung, and Blood Institute for funding the RECOVER study, and the participants who've enrolled and patient representatives supporting the RECOVER study. Thank you so much. I'm happy to take any questions that you have.